What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information straight from the specialist? Okay. Hello, Dr. Charlie Bell. Thank you for joining us today on Straight from the Specialist.
Pleasure. Great to be with you.
Can you give me a quick introduction of who you are?
Yes, of course. I wear many hats. So much of the time, I'm a forensic psychiatry trainee down in southwest London. Some of the rest of the time, I teach medicine in Girton College in Cambridge. And then in evenings and weekends, I'm a Church of England priest.
Oh, so it's an active thing.
No, that's right.
That.
So yes. So
you have a congregation.
Yeah. So I have I'm an associate vicar in Kennington in South London. And so yes, it's busy.
It's full time.
It's more than full time. The Church of England has a phrase non-stipendiary, which I like to think means that you just don't get paid for doing the work the people that do get paid for. So yes, it's.
So is it better or worse than the NHS?
It's good working for two slightly challenging organisations because when you're fed up with one, you can go to the other. Okay,
thank you. And what level of medical student do you teach?
So mostly undergraduates. So the Cambridge course is still pretty old-fashioned. So we have the first 3 years of undergrad, preclinical, and then into the clinical studies into the second half. So yeah, no, mostly it's those first 3 years.
Okay, brilliant. Thank you. And I've invited you here today as, is it the president?
The lead. Yeah.
The lead of Changing Face of Medicine.
That's
Would
right.
you like to tell me more about that organisation?
Yeah, of course. So this has really developed out of, it was actually the British Medical Association's president a while back, now Sir Palihunjan, who was, I think, aware that a lot of the current thinking around medicine remained within the kind of 5 year period. So
when was this? Sorry,
this was back in, I think, 2017. So quite a long time ago now. Actually, it feels not that long ago, but with the pandemic in the middle, it really is. And I think Pally's feeling was, we often talk about doctors of today and the things that we need to be able to do and the changes that are happening now. But actually, there's a bit of a lack of thinking about what's going to happen in 20 to 30 years' time. And that then makes a big difference in terms of what we should be doing now if we're going to be intentional about preparing for 30 years' time. Okay. So Pally's project started there. And then since then, we've kind of, we sat with the Academy of Medical Royal Colleges for a while and doing some work at a sort of arm's length from them. And we're now a separate think tank organisation that's trying to ask exactly those questions.
So separate to the British Medical Association?
Absolutely, yeah. So,
and separate to government bodies?
Separate to government bodies, and really very much doctor-run, doctor-focused, not because we're wanting to ignore other healthcare professionals, but rather because sometimes conversations around medicine become very kind of systems focused or become very much about the kind of medical ecosystem. And what we're really interested in asking is, doctors themselves, what is this doctor thing all about? What are doctors for? What will they be for? And focusing on the doctor specifically then allows us to ask some of the questions which I think we felt weren't always being asked and more importantly answered by people who are making policy on health.
Okay, interesting. Which then leads me nicely into my first question. What would you like to, well, do you know the format? Sorry, I'm going to ask you 3 questions. So what would you like to share with the general population? What would you like to share with GP colleagues? And what would you like to share with specialist colleagues?
Yeah.
So with your Changing Face of Medicine hat on, what would you like to share with the general population? And almost I want to start with what will the role of a doctor be with AI? Because I think the AI component is really important for us to think about now. Well, that's on the top of everyone's mind, right?
Yeah, I mean, I think AI is all over the press, particularly things like regulation and so on. People are still not completely clear what that's going to look like, and there's lots of competing voices in that space. But I think
outside of medicine, just generally.
Certainly outside of medicine, yeah. But I think what's interesting is that medicine, it's very clear that AI is going to have a significant impact on the way that medicine is delivered, on the life of doctors and other healthcare professionals, but also on the life of patients. And in a sense, is already beginning to have an impact.
How so?
Well, I think we're already beginning to see the use of AI, for example, in writing patient notes.
Note-taking.
Note-taking is the kind of new thing that people are
Well, it
using
frees
it
up
for.
time. I don't think I'm a very, I'm not a pro typer.
Yeah.
And cognitively, if it frees up that amount of headspace for me, then
Yeah.
I get to focus more on the consultation.
I think that's right. I mean, I think
Because you were talking as a psychiatrist, actually.
Yeah.
Could you just share?
So I think one of the really
again.
interesting things in psychiatry is that we'll often think about things like transference and countertransference. So the way that patients make us feel, and perhaps the way that the patients make us feel, we then reflect back to the patient. And so often a psychiatry consultation will be we're very actively involved in it. You're very much part of the consultation, very much part of the outcome.
And you think that's reflected in your notes?
I think so.
When you take notes?
I think so. And so I think we will therefore, so our notes are often an interpretation rather than necessarily just a factual account of what's occurred.
Totally unlike sports medicine.
Well, this is the
Just
thing.
anti-retroviral is positive or not?
But this is what's so interesting. So I read through my notes and I can almost imagine myself being back in the room again. So I feel like a lot of my feelings come out in the notes, which is of course one of the things that's perhaps kind of specific to psychiatry that you might not necessarily get in other specialties. But actually having AI writing...
Oh, sorry, they're some of the most wonderfully written notes that I've ever read before, written by psychiatrists.
And they do get to they do really, I think, that the classic joke that every letter says, dear doctor, thank you for referring this delightful 95-year-old lady, that kind of, which is the kind of classic medical note that people write.
For other specialties.
For other specialties.
Yeah, I know, it's so generic.
Whereas, of course, in psychiatry, it's okay to say how that particular consultation went and how the particular patient behaved.
It just reminds me of when of reading a novel, because you go through the description of what they're wearing, the affect, etc.
Exactly, and actually that's really important because we need to know those things.
You need to capture it.
Exactly, and actually, but I think one of the things that AI noted.
But how does AI do that? Sorry, how does it capture what they're wearing?
I think, but this is the thing, which is that AI notes in psychiatry are going to capture some things possibly more effectively than we do, but they're not necessarily going to be the whole story. So I might read an AI capture of a consultation and realize that there are things that happened in the consultation which I didn't pick up on because of my own emotional state or the way that I was responding to the patient or the things I thought were particularly important.
And that has happened to you so far?
Absolutely. And
so you're looking back at your AI generated notes,
Yeah.
and you almost feel as though they're more objective?
Yeah, I think so. But they don't necessarily, they're more objective in a sense because they provide more of a factual account. But then also as a psychiatrist, they also remind me what it is, the value added part of me being a psychiatrist, which is they don't have the interpretative element to them. So actually, in a sense, having both in front of me, the ability to both make my own interpretative notes, but also have more of the factual notes there, might also help me with things like risk assessment, meeting those things and finding those things which we don't otherwise pick up on. There's so much there that I think otherwise we just might not have in our armory, which we do get from the use of AI.
That's lovely, actually, to hear that you appreciate the fact that you're having both elements complement each other.
Yeah.
Whereas my worry is that, at least from a patient's perspective, they're now thinking, but what does the doctor bring? Because if if AI can be trained to read an algorithm and then to sense that from your symptoms, what is the role of a doctor?
Yeah, I mean, I think one of the big things that AI is really good for is triage. So that first stage of identifying, is there an issue here or is there not an issue here? But I still think there's an element of medical judgment which comes in, not just about what you then do with the information that's provided to you, but what you do with the information that's provided to you relative to the specific patient that you're seeing. And I'm not sure that AI is necessarily able to tell us what is going on, but it might not be able to tell us exactly how we should then approach that with the person in front of us. So I think
Can you give me an example?
Yeah, so for example, somebody that's coming in, so AI will be able to tell you what the tests show. So they'll be able to say, yes, there is shadowing on the left lung, or yes, there is a high CRP, or that there is a high cancer mark, or whatever else. But it might not then be able to say, Mrs. Bloggs, and how she responds to particular bits of news, or what's important to her, because you've got to know her over time. Thinking particularly in general practice, you might get to know patients over time. you know what this will mean to her. So what might be helpful for her when you're telling her these particular results? What are the questions that she might actually be asking you in this particular moment? And you might be able to find the answers to those questions via AI, but actually identifying and knowing your patient and identifying their needs and their wants and their sort of wishes, I still think remains a kind of human personal touch, which we're not yet at the stage that we can just ship off to AI. So I think AI can help us to be more efficient in how we do our roles, but I think there is still something very human about what it is that we're doing in those roles, which can't be taken by AI.
And there are. I'm also thinking from the patient's perspective. We're used to, over the decades, we're used to that human contact and the caring nurse that puts in your cannula, your Venflon. And then to remove all of that and just to have a computer screen that's telling you this is the diagnosis and these are your blood results, that just seems too difficult from the patient's perspective to be able to palate.
Yeah, and I think medicine is a kind of humanistic pursuit. I mean, there is something here about, I think there is the human-to-human contact, which does matter. And I think it does matter as a kind of, I think that is almost at the core of what medicine has been and probably will remain.
Good human contact.
Yes.
Because unfortunately, you hear these stories of how, oh, my GP knows nothing. I don't, and they're really dispiriting.
Yeah.
But I wonder whether AI will free up that time so the GP can then be more present.
Yeah, I think that's exactly right. So I think AI is a tool rather than a replacement. And I think one of the challenges which we now face is enabling us to use that tool effectively. And I'm not sure that we've yet necessarily had those conversations in medicine to the degree that we need to say, if AI is the tool that is going to free up your time, how do you use it best? And how do you come up with a shared agreement, a kind of collaborative agreement with patients that enables us to do that in a way which also is beneficial for them and is what they're looking for? Because I think it's very easy for us, again, as doctors, we often kind of think about what the doctor needs or wants and so on. And we're often wanting to do that because we're wanting to provide the best for the patient. But actually, is there something that we can do in our conversations and collaborations with patients that can say, this is the kind of thing that AI might be able to enable us to do? It might mean that you see your doctor less for the following things, but it might mean that you get to spend more time with your doctor being an advocate for you the rest of the time.
So that's a possibility that you're thinking about?
I think so. I think so. And I think we need to be alert to the possibility that that our relationships with our patients will be improved through AI, but we need to be intentional about what we're using AI for. And simply replacing doctors in a consultation room with a computer screen feels to me not to be something that doctors would want, but also not to be something that patients would want either.
Thank you. So in summary, what is that message that you're delivering to the general population?
So I think thinking about AI, things are definitely going to change. But AI is a tool. I don't think AI is a replacement doctor.
That's going to augment your care.
It's going to augment your care. But I think patients and doctors need to be engaged in the conversation about what that might look like and be open to the possibility that that relationship is likely to change between patient and doctor. But hopefully, if we get this right and if we're intentional about it, we'll actually change for the better.
Okay, thank you. Okay, so moving on, what would you like to share with your GP colleagues?
I think building in a sense on some of the things we've talked about with AI, I think one of the things that
it's going to be an AI dominated
it feels
conversation.
Like it's and
but I suppose it is the changing face of the world.
Exactly. And I think but there will also be changes in the way that or what people are expecting from consultations, what people are expecting from general practitioners. And we've seen all the frustrations that, I can't get a GP appointment, or I can't get access to my results, or I can't get is often the way that these things are kind of framed. And I think one of the things that AI...
Well, it's not instantaneous. And I think
of course.
It's not that you can't get... I think patients' expectations of the real world is Amazon delivers next day.
Yes. Yeah.
And then you've had your blood tests. They've been processed surely the same day. And why can I not gain access to it? And there's that disconnect of not understanding, why does it take so long?
Yeah.
Can you explain? Sorry, I know this is going back to the previous level, but why do these things take so long?
Yeah, so I think blood tests is a really great example. So I myself get frustrated when I can't, I think, and particularly as a doctor, I get even more frustrated because I think, well, I know how to interpret the blimmin' thing. Just give me the result.
Oh, so the problem is with the interpretation that the GPs don't want to send it out immediately.
Which is totally reasonable if you see it from a GP's perspective, which is, I don't just simply want to give people a load of numbers on a piece of paper and say, here are your, that's not actually giving somebody their results. Giving somebody their results requires a level of interpretation of an analysis of what the risk is within those results, the level of uncertainty, what the patient might be able to understand or not understand based on the information provided to them. So it's not just about information, it's also about the integration of information and the interpretation of information.
And that's what you're waiting for.
Exactly. And that's actually what you're often waiting for. But the problem is, at the moment, you are also often waiting for the things to come through from whichever, we're waiting for the results to come through from the hospital. We're waiting for GPs, for example, to spend half of their time writing up the consultations that they spend the rest of the time having. And so there are elements here which I can see speediness increasing and GPs being freed to do particular other things. And I do think general practice, the kind of thing I'd say might happen as we move forward in general practice is that general practitioners might be able to move back, in a sense, to being advocates for their patients, rather than necessarily primarily diagnosticians.
Oh, so explain that concept for me. So you're saying because we're going to free up the paperwork burden.
Yeah, but also give GPs tools that they're able to integrate results, for example, rather than GPs often ending up with a set of results that raise red flags, which then require a referral on, for example, to a specialist. There may well be specialist pathways that don't require a referral on to a specialist, but rather that are able to integrate results that can happen at GP level. For example, sending a patient.
Could you give me an example?
Yeah, so send a patient for example, you have a patient who needs to go to a 2-week wait because you're worried about lung cancer. Now, at the moment, you would send them through to a specialist, and at the stage of seeing a specialist, then scans would be organised, and then there would be another kind of level of triage as to whether this really is or does not require further follow-up. That kind of stuff could then be managed at the level of the general practice. Because then you might have an integrated pathway in which you could get the scan done. The scan could then be analysed by AI. Algorithms could be put in place, and I still think we're allergic to algorithms as doctors. I think we see algorithms as being a bit dodgy, but yet a lot of the literature suggests that algorithms really are good when they're used properly. Actually, algorithms can outstrip clinical judgment, and we don't like to hear that. We don't like to think about that too much. But actually, for things where we could enter in information and get out likely risk and so on from useful.
Well, it standardizes everything.
Exactly. But it also means then that the GP then holds, so if we get back to the kind of old school thing of everybody wants to know their patients, you want your own named GP, your family GP. Actually, if GPs are able to spend more time with patients rather than spending time writing up notes and all the rest of it, it's not only about note taking, but that's one of the examples. You'll know your patients more, you'll have more opportunity to know your patients more. And if you know your patients more and you have access, for example, to the first stage of a referral pathway that's then managed at general practice, you're able to advocate for your patient. Well, what is, or have the conversations with your patient. What is important to you here? This is the level of risk. This is the likelihood of this particular condition. Do you want to have it further followed up? These are the things which are really important to you. You've always said in the past that these are the things that matter to you. So do you want this to be followed up further? Do you want me to follow this up with you? Am I able to travel alongside you in some of the following, rather than you being handed over to a specialist, the specialist does their stuff, and then eventually a letter is sent back to the GP. Can the GP actually be part of that long-term pathway for patients in ways which I think most GPs really want to?
It just sounds like a better way of practicing, like going back to GP roots, being the family doctor.
Exactly. And I think this is why this is a win for everybody. It's a win for patients because they have access to an advocate.
So you think the future of, sorry to interrupt you, but you think the future of being a GP possibly looks rosier than it is now? I
hope so. And I think it can do, but again, it comes back to what I was saying before, which is we need to be intentional about this. Actually, it's about
and direct the movement.
Exactly, rather than, which is the kind of classic medical thing, which is things happen to us as doctors, and then suddenly we're in a new place and someone else is doing this and another healthcare professional is doing this part and so on, and then the doctor kind of picks up the bits that other people don't do. I think what we're looking at as a a kind of group is saying, let's be really careful and intentional about what we think being a doctor would look like in that kind of scenario that would be really helpful, not just for our own professional development, but actually for patients as well. What do patients want and need? And that needs to be tempered by what can be delivered. Because I think we need to have those conversations about patients' wants are not always what can be delivered.
So is there a patient group looking into the future of medicine? Because yours is a doctor.
It is, but we're very intentional about including patients in each of our conversations that we have. And of course, including patients is one of those phrases which sounds great, but is tricky because there's, of course, professional patient groups, so groups that work, that are very much kind of engaged in the patient conversations around these different changes that are going to come about, but also all of us are patients in a sense, but we're medically informed patients, which is a different kind of patient possibly to others. So recognizing the heterogeneity of the patient population, I think, is important, not least because as changes come, we often think about wearables for, people being able to monitor their own health and so on, but there's often cost implications to that. There's often, our patient load across the country is not the same. We have, much like the population in general has all kinds of levels of education, of financial ability, all that kind of stuff. It's very easy to kind of imagine one particular type of patient and say, well, the patient perspective is X. But actually, there's a huge variety of different patient perspectives, which comes back to the question.
It's a rainbow spectrum.
Exactly.
I mean, it's not even a grayscale.
And that comes back to the GP question, which is maybe some patients will really want one particular thing from their GP. Other patients might want, we particularly see with things like telemedicine, some patients just want to come in, this is my symptom, I want to be treated. I actually am quite happy not to even have much personal contact. I want to just give across my symptoms, particularly for quick treatable things. I want to have my symptoms dealt with and then I want to be off. And that's something then about this patient contract with medicine more generally. Are we able to provide different streams for different things and for different patient groups that might then allow patients to get what they need and want from healthcare professionals, which might mean that doctors are different things in different circumstances, and that we might have a coordinating role as well as a patient-focused role.
Thank you. Happy with that?
Yeah.
Perfect. Okay, so our final question is, what would you like to share with specialist doctors? So an area that's excited you, particularly in the changing face of medicine over the past year, that you want to share with other specialist colleagues like myself.
I can't remember what we said. There was something quite good for this. Sorry.
No. There was
something
worry.
that we were going to specifically mention. I now can't remember what it was.
So, I mean, I was particularly curious about how you're going to plan for the training requirements. So in terms of funding and then working with governments, because now we don't have an NHS England.
Yeah.
You'll probably need to educate me. Like who
Well,
advises?
we don't know. But yeah, no, that's fine. We can, yeah.
Okay. Yeah, no, continue.
Okay.
Oh, don't worry, I can edit.
Okay, great. I think one of the things which has genuinely excited me is that finally people are beginning to ask and answer these questions.
Ask what questions?
Ask the questions about how do we intentionally change? Because so much of medicine has
for the
been,
future.
For
How
the
do we
future.
intentionally future-proof ourselves?
Yeah, future. In so much as you can future-proof yourself, because I think one of the
That
things,
sounds really protective because we're worried.
Exactly, and I think we are worried. So I think there's a deep anxiety. I think there's an anxiety amongst the general population. When was the last good news story?
And there is an
that you hear?
anxiety, because I was talking to you earlier how usually when I have guests and we're talking about things like chronic pain, I still like to have an angle of hope attached to it.
Yeah.
But there's no real way that I found during our preparatory work to flip this. I'm still feeling anxious. I'm feeling it inside.
Yeah. And actually, I think anxiety runs through a huge amount of this, particularly for those of us who are doctors.
Correct.
Because there's this feeling that the world is moving around us.
At a rapid pace.
Very rapid pace. Much of the things which we've always thought are doctor things are no longer kind of within our preserve. They're no longer things that only we do. And I guess in a sense, there's this kind of shrinking thing about what it is. I think we find ourselves doing things which don't particularly enjoy doing, at which we don't really feel like we spent those 6 years of medical school and, 300 years of postgraduate training to prepare for.
Yeah.
That actually a lot of the stuff we do does not feel particularly doctory. whilst at the same time not really having a sense of direction about where we're going. And I think one of the things which I'm increasingly kind of encouraged by is that people are beginning to say we need to start asking these questions intentionally and say, let's really, and that's what the changing face of medicine is about, saying, let's imagine the doctor in 20, 30 years' time, rather than
Is this long term, 20 to 30?
Yeah, exactly. Okay. And not just, let's not just allow events to run away with ourselves where we end up with a kind of organically created, not terribly satisfying version of a doctor. But actually saying, what might it be? What might that look like? Going back to your point, what might that look like if we lost some of the anxiety and we thought about what might it be to have a rewarding career as a doctor in 30 years' time?
I like the way you phrased that already.
But it's really easy to get anxious, isn't it? Because I think because we do see things being eroded. We often hear about the erosion of professionalism in the medical profession. But the problem is, this is going to require us not simply to engage with...
What is the erosion of professionalism? Sorry.
I think people increasingly see our roles being taken to other healthcare professions.
Okay.
I think we're increasingly being seen as employees rather than necessarily as the kind of, the old school idea of the doctor as the kind of artist and scientist in one that kind of comes in and is the sort of overarching decision maker and kind of maybe thought leader within a healthcare team. I think we're increasingly seeing that being challenged both by other healthcare professions, by policymakers, by government, and also by patients themselves. We're no longer that kind of... The paternalistic era is over, but we haven't quite worked out what the kind of advocacy era looks like. And I think that is where we're moving into. We're into a kind of collaborative advocacy for patients.
That's a personal opinion or changing face of medicine opinion?
So it's certainly something that's come up in our conversations in the changing face of medicine. I mean, for me, that's definitely where I think medicine is moving towards. But I think that's also, we're in a strange system in the UK because in the US, for example, these conversations are happening around the world, but in the US and the UK...
So not just developed worlds.
No, absolutely. And I think that's the other thing, which is thinking beyond the kind of, the rich world conversations, but actually thinking, so it talks about AI quite a bit. What might that mean for people in developing countries now? How might we think about healthcare provision? What might AI do for diagnostics, for example, in countries where patients can't get near a doctor? How might we make use of those? How might we do that ethically? But how might that relate to treatment as well? Because as we all know, having a diagnosis without treatment doesn't feel terribly satisfying and has a number of ethical concerns around it. So how might we engage with those kind of questions that moves beyond just providing an ever-increasing kind of technology-infused healthcare system in the UK, but moving to a global conversations about how might AI be useful globally, not just in the provision of healthcare, but in the development of drugs or in the development of technological solutions to things.
Yeah. Maybe naively, I was most excited about that.
Yeah.
About how you just review masses of data that we may have collected.
Yeah. Yeah.
And just... my heart glows when I think about how AI is well suited to that.
Yeah.
But there's something that's holding me back about accepting fully and embracing AI when it comes to the patient-doctor relationship. And that's maybe because I feel threatened. And I wonder whether that's...
Yeah, and I think there are also genuine concerns. So data protection is a genuine concern, data security, for example. So in a sense, AI offers the potential for personalized medicine at a fraction of the cost that we thought it would cost, because it's able to do those integrating processes where it takes all the information about a patient, takes big data, takes all of these things, and is able to essentially...
But do you think it's there now?
I think it's very close to being there.
You do?
Yeah, I think so, but I don't know.
I don't. It's still, my note-keeping app still doesn't know how much vitamin D I prescribe.
I think the potential is there.
I agree.
I think it's I don't think we've harnessed it.
I don't think it's anywhere close on a practical level.
No, and that's possibly also us speaking from a UK perspective. So I think particularly from an NHS perspective, the NHS is notoriously slow at adopting new technologies or new ways of thinking or doing things. And I think that is one of the problems that we face, which is we do run the risk of these things running away from us.
Yeah.
And I think that comes into training as well. So in the NHS system, we are training our doctors to provide.
Oh yeah, coming back to our original
exactly.
question.
So we're providing current treatment. We're service provision from our resident doctors, our junior doctors, whatever the current terminology is. We're providing current treatment, and we're providing current service provision. Whilst then the challenge is, but how do we train those people to be able to do stuff in the future?
24-year-olds, 26-year-olds who are coming out of medical school. We actually need them to provide a service of being the on-site doctors in a hospital.
Yep.
However, when they become consultants in their late 30s, 40s, maybe 15 years after they've left medical school, the world is going to be a very different place.
Exactly.
So how do you plan for that? How do you plan for that?
And how do you plan for that whilst requiring them to be doctors of today? And I think this comes into back to the AI questions and all the things about are these processes, are we really going to be able to do all this stuff? Which is, how do we do it alongside providing today's medicine?
So are you answering my question with a question?
I'm afraid I probably am. But I think the potential is there. I think that will require a fundamental rethinking of the way that we do medical school. And possibly rethinking about how we do medical training. So
on a practical level, are you advising the government? Or what do you have planned for the next couple of years?
So our role has really been to try to get these questions into the policy sphere. So to say, we need to, yes, we often talk about, we talked in our conversation earlier about the kind of endless destruction or demolition of various bodies in healthcare. So we've lost each kind of passing week. There seems to be another kind of policy.
So at the time of this recording, we've lost NHS.
NHS England just gone. Yes, exactly. And who knows what it will be by the time it's out. But in a sense, those bodies have been making waves and having conversations about we need to think about what the doctor of tomorrow looks like. But often the doctor of tomorrow literally is the doctor of tomorrow. We're looking into the next week or the next 2 years. We've been trying to say in those policy spaces...
Is this a problem with our elections? Is it done every 4 years? Why are we so short term?
Yeah, I think it is partly that, but I think it's partly the anxiety which we've spoken about today. So I think there's anxiety amongst doctors to have these conversations. There is the impossible problem, i.e., this is just too much, and we can't possibly think about this intentionally. So we're just going to hope that everything will happen organically, and we'll respond to events or react to events as they come along. So a lack of kind of strategic thinking at the centre. I think medicine in the UK struggles also from being so fragmented in terms of its leadership. So you've got so many different bodies that are none of which quite take the lead or the responsibility for developing this kind of strategy.
Do you think there are any countries that do it better than us?
Well, I think it also...
I don't.
No, but I think it also depends on how medicine is provided. So in socialised medicine, it always becomes tricky because then we're talking about a medical system rather than necessarily about the doctor per se. So I think in some organisations where, for example, thinking about the US, and I'm not advocating for the US system, but if you think in the US where you have a particular private organisation in which you will have conversations going on about what the doctors that they are employing, the doctors that they want to retain within their particular private organisation, and why it might be worth continuing to be a doctor. What might be the benefit of doing that role? Patient satisfaction meaning money, not just simply meaning satisfaction. I guess in a sense, those questions become more acute in that kind of setting. Whereas for us... In a profit-driven setting. Whereas in our setting, I think they're just as important and potentially more important. But where do you have those conversations? And that's what we're trying to do, which is to spark those conversations through webinars with experts in particular parts of this. So whether that's the green agenda, whether that's in AI, whether that's in training and education. But also we're hoping to have a big conference in the not too distant future, bringing together people into the room who otherwise might meet in meetings, but might never actually have their kind of feet held to the fire on, okay, we've talked about 2 years hence. Now let's think about 30 years hence. And let's in a sense, not wipe the slate clean and imagine doctors don't exist now, but let's not worry about those endless sort of organic changes and think about what might good look like, what might excellent look like. And that might be 4 or 5 different visions, but what might that look like? And then how do we get there?
Okay. Thank you. That's call to action then. So can anyone join these webinars?
Yeah, absolutely. And so they're normally advertised on our website and they're shared. So there's a number of webinars that you can find on our website at the moment that have public access, and that ranges from, as I said, things like the green MDT through to the use of AI and sustainability more generally. And then the conferences will also be advertised on the website and anyone can attend. And the key thing for us really is this is not merely for policymakers or people who are usually in the policy sphere. It's also to say to jobbing doctors
to contribute.
We need to hear, because I remember working on a project with a large policy group about 5 or 6 years ago, talking about IT in the NHS. And it was all very high-minded and very kind of high level. And it was about how we ensure that this connects to that and how we ensure that kind of large-scale infrastructure is put in place. And I remember being a jobbing doctor at the time saying, one of the problems we face is that all of these things sound fantastic, but actually our GP records don't talk to our hospital records, or we don't have access to intelligent printing, or things which are actually very basic in a sense, but which actually matter if we're going to achieve those long-term gains. And so in a sense, for the changing face of medicine, we need to know about the things that are on the ground that are frustrations
from a junior level perspective, all the way up to the top.
Absolutely. And which sometimes don't make their way into policy corridors, because
or even in those conversations.
Exactly. And actually,
or the table.
What have you learnt we often will hear from medical schools about what they're teaching, but actually what we also need to hear from is people about what they're learning. So yes, there might be an intention to enable students to find the medications from searching on the BNF online or something, but actually, have students learnt interpretative skills or analytical skills, or do they feel that most of what they're doing is still learning by rote? And so what are the barriers to actually seeing this stuff change, rather than our kind of often very, very kind of high level sort of painting with primary colours decision making that we make, which is this is how we're going to change things, without realising what the impact on the ground might be.
Thank you. Thank you for coming. Thank you for sharing all of those wonderful pieces of information. You've made my mind think a lot, possibly too much for a Monday morning, but thank you for speaking so well about it.
Great. Thank you very much. Great to be with you.